Thank you for getting back in the room. So it's a pleasure for me to tell you a little bit about the interventions we're doing in the breast. And if you'll bear with me for the next 25-30 minutes, I'll tell you why breast radiologists are so excited about interventions, and I'm not an exception. So we do know that the procedures has significantly, image-guided needling has significantly expanded the role of radiologists, of breast imaging, and this also has really, in a big degree, changed the way we are managing the breast diseases. So radiologists now is not only detecting abnormality and evaluating it, but also actually takes role into management of disease. So what we want from procedure, we want it to be safe, accurate, cost-effective, and preferably, which ultrasound provides us fully, it's a real time. So we can see what are we doing, where are we going, we can control fully and completely what are we doing, and make sure we're assessing good results. So ultrasound as a guiding modality we would use for several cases, most often for tissue sampling, marking the area, preoperative localization, which is a big thing, and we are helping surgeons and patients. And a big role, and it is increasing over time, is therapeutic procedures, and I will stop on each and every of these points in my further talk. So what do we do before intervention? So we do know that the patients who are about to get any kind of needles, most of the time are extremely anxious, they're scared, and we're there to make them sure that we're not going to miss anything, we're going to do things the best we can and obtain the best results we can. Consent is a big thing for tissue sampling, let's say, or a marker insertion. I would say verbal consent is fine, so you just explain procedure to the lady and get her verbal consent that she's happy to go on. Therapeutic procedures would require written consent, but I believe this is very country and center dependent, so some of us would ask for it, some of us no. In UK we do, because this is actually a small surgical procedure rather than just a diagnostic one. Precautions, we all know we have to clean the skin has to be clean. None of the procedures is fully sterile, but we try to keep it as clean as possible. So we clean in the skin and we're doing the locals. Because the anesthesia is local, not the general, we have to still be aware about the allergic reactions lady would have, and we have to make sure that there won't be surprises for her or for us when we will start the procedure. So let's go one by one, and let's start with the tissue sampling. So we all are familiar with the imaging, but there is only one way how we can confirm the morphology, and this is a tissue sampling. And depending on the size of the sample we're getting, we can get FNA or fine needle aspiration biopsy, we can do the core biopsy, different sizes of needles, vacuum biopsy, bigger biopsy, and open surgical excision. So when we're talking about the fine needle aspiration, we're using smaller needles. We aspirate the fluid if that's a cyst, and we're doing just getting some cells and spread them over the slides if it's a solid lesion. Very often in our practice, we're having a cytologist with us, not because they wouldn't trust us to make samples, but it's just the practice the way it is, and they are the ones who are spreading the sample over the slide. They also are able to provide us results in 20 minutes, which is extremely convenient in a one-stop clinic in a very tense clinical settings. So the minus of this procedure, if we are talking about the solid lesions, is that there is quite a large amount of insufficient sampling. But it's still good enough if we are talking about lymph node sampling, if it's enough, If we are having a cyst with a dense content, we're quite happy with FNA as a first line procedure. And also, if we can't really do the core biopsy, if the patient at the moment is on anticoagulations, which would not allow us to do the biopsy without stopping them, if the finding is very close to the chest wall, very close, I don't know, just areas which we can't safely assess, let's say next to the vessels. And if the patient is, for example, too old and fragile, and we know we will not do the biopsy. Sometimes patients are refusing the core biopsy. They would rather go with the FNA. And in that case, we're just highly respecting patient's decision. And sometimes this is not the good practice to do the cancer treatment based on FNA. But there are some cases, if we can get the receptor status on FNA, we would go and start treatment, let's say, with letrozole, with hormonal therapy, based on this, which is, again, not perfect. So this is just an example. There's a needle in the cyst, and cyst had a dense content, but that was just an insufflated cyst, so everything was fine. Coordinated biopsy obtains slightly bigger sample, so it's also more accurate, provides us more information, and it has a high specificity and sensitivity regarding the tumor grade, receptor status, HER2 status, and other tests we can get out of these samples. So number of cores, I would say, depends on center practice, and you yourself would know the best. How much would you take on default? I would say 3 is enough. Sometimes if the lesion is very small, you're taking 2 and you're happy. Sometimes if area is more of diffuse architectural change, you would take 5 or 6 just to get enough samples, because none of us wants lady to go through that one more time, come back again, delay treatment, delay results. So we just, I think quite a lot of times we do just act upon the situation. Size of needle is very variable. Most often it's 14 gauge. Sometimes for nodes we use smaller needle, 18 gauge, 16 gauge. Sometimes, again, if it's very much dependent on the situation we see on imaging, we could go with 11 or 12 gauge core biopsy needle if it's an area of calcifications, for example, we can see on ultrasound. But in average, on default, we would use 14 gauge needle. So here you can see small, quite well-defined mass lesion and a core biopsy needle through it. What is important to make sure that on your multidisciplinary team meetings, when you're discussing the patients, if you can actually prove that you've been in a lesion, so it's kind of perfect to have an image with a needle before firing and after firing, just to document what you've done. It's very important to remember, and when you're in a tense clinical settings, you sometimes just quickly press the freeze button and that's you, and then you realize the body icon is wrong and the marker is wrong. And if you can't amend your report and mention it, do it so, because it's very, very important. You're really documenting what exactly you've done for future management. And as I said, 3 samples most of the times is enough. Large volume biopsy, we are taking more extensive sampling, and most of the time this happens because we would have inconcordance between imaging and pathology. So we're pretty sure the finding must be malignant. It looks malignant, and a simple standard core biopsy does not provide us these results. So we would go for the large volume biopsy and provide the bigger sample to the pathology. And if they're coming back and saying your big sample shows nothing else apart from the same findings and the reaction to the previous biopsy, we would be okay. But we really need to make sure that we are having we're on the same page with the pathology. So we're using 7 to 11 gauge needles for large volume biopsy. Most of the time it's 10, but it again depends on the center settings, how your machines are equipped and set, and who's responsible for buying the needles. The bigger, the cheaper, I believe. The more you're buying, the cheaper. And then what we're doing, again, this is a standard. We would use medication containing adrenaline just to help to cope with the bleeding, which will be there. It's inevitable. So really, really, we have to check whether there have been previous allergies and try not to inject anything that contains adrenaline in the skin. You can have very, very bad necrotic reaction of the skin. They heal very badly and look very badly. So if you would ask me, if the lady is allergic to adrenaline, and the way you can know it, you can also always say, so this is a medication your dentist is using when you're going to extract your teeth. Have you ever had any issues with that? And if she says no, you're safe. But if they do, they know. So can you use locals without adrenaline? Yes, you can. You just have to keep in mind that the bleeding will be longer. You will have to keep a pressure on the breasts a little bit longer and keep the patient into your room, ultrasound room, just a little bit longer and make sure she's not bleeding afterwards. Let's move to marking. So marking the lesion is a big thing. It's a great thing, and this is what we can do. So the skin mark it's more related to the preoperative marking. So this is not a real marking as we would understand this. So we would just draw a little tiny cross above the lesion. If the surgeon requires that, we would do this on default anyway. But the marking with the coiled markers, I would more go into this. So what is important, if you are sampling multiple areas, especially if they're close to each other, and especially if they don't really look similar to each other, please use different shape markers, because then you'll be able to reflect. If the pathology results are different, you will be able to say on your MDT, let's go for the ribbon marker, but we won't touch the spring coil because it's benign. So as the MRI is being done more and more nowadays, the MRI compatibility is a big thing. We have had cases when we're placing a marker and lady is undergoing chemotherapy. But after the marker has been placed, we're seeing that it actually sits at the edge of the tumor, which is 5 centimeters. And after chemotherapy, it's 3 millimeters. And it actually sits away from the residual tumor. But on MRI, the artifact from the coil is so big, we can't see residual tumor. So it might result into very big surgery, which is not necessary. So the markers are different in shape, and they're very different in material as well. Most of the time, they're titanium or steel, but there are more and more coming polyurethane or some kind of plasticky material coil markers, which are absolutely great. So these are only a few of them, and you would recognize which one of them you're using in your practice. So the manufacturers are producing them, and they all do the job. But some of them do better job than others. So this is just a few of the pictures how we can see markers on ultrasound. Not all the markers are visible on ultrasound, and not all of them needs to be seen on ultrasound, but it's good if they are seen on ultrasound. So this is just a small plastic material, and it looks like a little tube, and it's excellent. It's excellent on MRI, and it's excellent on ultrasound and the mammogram, and we really, really like them. They are cheap as well. On the other side, there's a hydromark, and you can very nicely see that as well. So hydromarks are visible in ultrasound. So in this case, we have 3 different areas marked. So you can see 3 different shapes of markers. So at the back, that's a stereo marker here. This is omega shape or R shape, depending on how you call it. And then there's this one is an ultra clip, which is used the most, and that's a beacon, which is the one we really, really like to use. So they all have a very good compatibility with all modalities, and the ribbon one, the ultra clip, is the only one we really can't see, but all the other ones we can see on ultrasound. And nowadays, when we're picking up so many things, this is not an unusual situation when a patient is coming for localization, preoperative localization, having 3 different shape of markers in the breast, and we clearly know what we should do with them, which is great. So preoperative localization, as I said, I wouldn't call skin marking localization, so we just draw a little cross on the skin, and we would do this every time after we are putting the marker in, the wire in, so the surgeon would just know where the tumor projects over the skin. I remember when I just started to work, the patient came for localization, and all they had was a WLE written under the clavicles. And years has gone, and now ladies are coming, and their breasts sometimes look like cartoons, so there's bits and pieces drawn everywhere, because this is the way the surgeons are planning their surgery. So that takes a lot of effort and challenge for us as a radiologist to give them information they ask, and we can do that. So most often, we are using the wires to localize the lesions before the surgery, and the wires most often are inserted under ultrasound guidance or stereo or MRI if we can't see the lesion on either of the modalities. So potentially, what can go wrong or what can not be good with the wires? So they are slightly uncomfortable for patients. They tend to displace in a fatty breast especially. And even if we're letting patient go happy with the wire position, we've done a post-procedural mammogram, and it's there, surgeon comes afterwards after surgery and says, you know, the wire was like 15 millimeters away from the coil, and this just sometimes happen. So the wire can break in a breast. We have had this situation a couple of times. Technically, it might be a little bit difficult in a very dense breast because you can't push the wire through. It's quite soft, and it just doesn't go where you want it to go. Sometimes it's on a surgeon's way, or so we always discuss all the cases, the preoperative localization cases, day before the surgeon comes, and we sit together, we explain how we tend to do this, and we agree how we're going to do this, and we always need a post-procedural mammogram. Mandatory what we have to do if we are marking several areas. Let's say there are 2 small foci of malignancy in a breast, different quadrants, and surgeons saying we can take them both out, there's nothing in between. We've done appropriate investigation assessment before that. We would put 2 wires in or 3 wires in. If the wire slips out, we don't pull it out, we just leave it and insert the correct wire. But in that case, we mandatory have to mark the wires ABC, 1, 2, 3. Well, choose your own way how to do it, but that's what we have to do. Again, just a very, very few samples you would recognize the wires would use. There's not all of them here. They are very different in shape, in the way they deploy, in the way they hook in a tissue, in the way they come out, and there's a certain preferences, inevitably, of course, as well. It's just to give you an idea how the wires look like. They all are sitting in the needle, so we're placing the wire in the breast and then removing the needle, and the wires stayed hooked in the breast, in a tissue or in a tumor. So here you can see there was a small invasive ductal carcinoma grade 2 just behind the nipple, and we did put the wire through the lesion, which was more looking like a small area of distortion. So this is the wire going through. We have to make sure that the hooky thing is behind the tumor, and it's very easy if you slightly pull it. Just move it. You can see where exactly it sits in the tissue. Don't pull it too firm because you will just pull it out. And then this is where the wire sits. What we're doing, we're describing how the wire sits in the breast. We're describing approach, how did we went, where the wire is. So our surgeons love beaded wires. So they want us to put the wire so the tumor sits or the coil sits between the first and second bead of the wire. And if we've done so, they're happy, and we want them to be happy. So we also put some skin markers. So this one is where the marker, the wire goes through the skin, and the other one is on the nipple, so surgeon can review the imaging before the surgery and be happy with what he sees, and he can make some amendments in a management if it's needed. Another case, so there were 2 areas targeted. So the area 1 was a tumor, the area 2 was a little coil marker, there was a B3 area of typical changes, and the surgeons felt they would feel safer to remove it. so 1 and 2nd area. So both wires are marked. There are, as I said, skin markers, nipple mark, and the patient had the surgery. The other way, which is new and very rapidly developing, but still developing, is localization with seeds. So seeds is, as I said, new technique, and this is used as an alternative to the wires. There are certain amount of benefits. So the seeds, finding the seeds is based on a wave it emits. So it could be a magnetic wave, it could be radioactive signal, or radio frequency signal. So it's a really small metallic seed. You can see how small it is in between the fingers, and shape-wise, it's most of the time the same. And it can be implanted into the lesion up to 30 days before the surgery. So this is a huge benefit. It means the patients are not crowding in a day of surgery in ultrasound room or radiology department. They can come at their convenience and have their seed implanted. And then at the time of a surgery, surgeon, depending on a seed type, is having this very specific seed sensing probe, and they are very accurately locating the lesion. So that helps them to remove the area and avoid further surgery. So I think this is a very promising technique. It can be used also for localization of the calciums if you use them for bracketing. So it's just to give an idea and another idea for surgeon how to localize the lesion. So, as I said, the localization of the seeds improves scheduling, so you can plan your departmental time better, theater time better, radiologist and surgeon's time better, and it's a very tense situation with a specialist anyway, so this is really big thing to think about. So patients are very good taking these seeds, so they don't have to walk around with a wire, so they do feel good about that. And then some of the seeds are not radioactive, so this is another big benefit. So it saves radiology time and operating theater time, and you really can plan this procedure beforehand, which is a big thing. Therapeutic procedures, there are few of them we can do under ultrasound guidance, and I think this is the bit which is so satisfying. And when the registrars and the trainees are coming and draining their first cyst, you should see, you probably have seen the big smile on their faces like, I did it, and yes, you did. So drainage is the simplest procedure we can do to help relieve the patient status. So we can do this for cysts and we can do this for abscesses. So with the cysts, we would not drain all the cysts. Well, I would say at a certain time of the menstrual cycle and a certain time of life, each and every lady would have a cyst, bigger or smaller, better visible or no. So we would not never ever drain all the cysts. But if it's a tension cyst or lady is concerned or it's a symptomatic cyst, it presses, causes pain or creates a lump, then yes, just go and do it. It's a very quick and easy procedure. Complicated cysts would require drainage as well. Simple cyst, if you're happy with the content, so it's not bloody and it's really clear. You don't have to send it away for cytologist, because cytologists will be only happy for that, not to check all the cysts. But whenever you're getting one of those contents which are slightly concerning, just send it away. Have your peace of mind, then give patient her peace of mind. And abscess drainage, of course, should be done under ultrasound guidance as well. So if there's a complex cyst, if you're draining the content and still something stays in the breast, in a cyst which does not look like dense cystic content, do the biopsy, because that can turn out to be something not good. So the most efficiently if the drainage is actually done by a person who's doing the scan. So that can be done real time and very, very quickly as well. So this is just to illustrate, this was not really of as simple as that was a seroma closer to underarm to the lady who had a surgery. So what we saw this well-defined oval-shaped lesion with some internal echogenities, but all over we had an impression of a very cystic content. So what we did, we put a needle in. With the surgically treated breasts, when we're draining seromas, we quite often prefer to not to use the needles, but use the vein flows because they're plastic. We're removing the sharp bit and the vein flow stays in, so we can move it and just drain it entirely. So this was the case, and you can see the double lumen here. So this is just nearly drained cyst, and this is what we had. So it completely resolved, and all we could see is just a little bit of a plastic tube. Abscess drainage, this was an abscess, quite large and quite nasty, so very close to the nipple. We put a needle in and we drained the pus, and in this case it resorbed completely. If they keep collecting again and again, we would put the drainages, the proper drainages in, and most of the time, and the best of the time, especially if they are deep or not easily found, it's better done under ultrasound guidance. Removal of the lesion, there are several types of the lesion. I will tell you a little bit more about the large volume excisions, which is something that takes more and more role into breast imaging and management of the breast lesions. There's also thermoablation and cryotherapy, which is an excellent ways of slightly more equipment requiring than the large volume excision, but still is used with a very, very, very good results. So large volume excision, most of the time there are several groups of the lesions we would remove with the under ultrasound guidance with a large volume equipment. So most of the time that would be in a screening settings used in concordance with B3 guidelines. So if the pathologist is given us report and saying that there is B3, which covers certain list of diagnoses, and if we are allowed, if the management allows us to do minimally invasive procedure, which is large volume excision, we would go for that. If the patient after biopsy requires surgical excision, she's just going to the biopsy, to the excision, sorry. So other group is removal of benign lesion. We have to prove that they are benign on a cytology or histology, and we can do this, and we are doing this with a very big success. So it helps to reduce and relieve the theater times. They don't have to do the fibroadenoma excisions. They can do cancers, they can do more complicated surgeries, and radiology can take over the bits we can take. So the tolerance normally to the large volume excisions is very, very good, and patients are very happy to get it, and it's very beneficial to patients. So instead of getting general anesthesia, they're getting local anesthesia. The scar, the incision in the skin is 4 or 5 millimeters. We don't require more, even if we're going with a 7-gauge needle. The scarring after surgery is very small. If we are keeping the level of infection is very, very low as well. So the patient's spending very little time in a hospital and is happy to go home in an hour time, which is great for patients. They do appreciate that. So the minuses of the large volume excisions would be that we can't really provide margins to the pathology, which is crucial to confirm whether we have removed lesion completely. But as I said, there's a certain list of findings which we can afford to do, and we would not need to provide the margins to the pathologist. There are situations sometimes that something which comes back as a B3 is upgraded as a B4 and is suspicious for malignancy. In that case, the surgical excision would take place. And then it's very important that we are putting coil in after each and every excision. Sometimes you probably might face this in your practice. Coils tend to travel away in the needle track, but they would travel back and even if they are slightly away from the actual area of the biopsy, that's absolutely fine. It's always in a near proximity, always. So we have to do post-procedure mammograms always to see if we have removed the tissue. So because the large volume excision actually involves inserting the needle in, and you are keeping hoovering out the tissue as long as you don't see any tissue anymore. You sometimes confirm this on mammogram. I'm saying sometimes because if you're removing fibroadenoma to 22 years old lady, you wouldn't do the mammogram anyway, because most of the time she wouldn't get a mammogram before the procedure, just the confirmation of the benignity of the lesion. And in our practice, we would do follow-up ultrasound scan in 6 to 8 weeks' time, which is a time when a post-procedural changes absorbs. If there's a hematoma, it absorbs, and we can assess the area and see if the results are good. There are different systems and different machines nowadays. I'm more than sure I haven't put them all on my slide. These are the ones which are most often used, as well, at least in Europe, on different manufacturers. So what are criteria for excision? It's actually, you can excise almost anything with ultrasound, guided large volume excision. We would be careful if the lesion is very close to the nipple, behind the nipple. So I would say at least centimeter is required, because it's quite tender when the locals wear off, and also the scarring after procedure can result into a nipple inversion, which is not something you would want after your procedure. Location very close to the skin is not a big issue, because like in this case, you can always inject a little bit of saline and push the lesion away. Lesion location very close to the chest wall, again, it's not really something, because you can inject locals underneath and push the lesion forward. And then again, the way you're doing the procedure, you're placing the needle underneath the lesion. So it's not an issue location very deep to the chest wall, close. So it's just a few steps what you see on your screen when you're doing large volume excision. So this lady had a fibroadenoma, very well defined, proven on histology. That was a fibroadenoma. She wanted this to be removed, and she came for a large volume excision. So what we did first, so a proper freezing of area, and the needle is placed underneath the lesion. I would say it's slightly too deep, but it took only one sample, and fibroadenoma moved toward the needle anyway. So you also want to be sure that the aperture, when the needle opens, sits just underneath the lesion, so you don't have to reposition it. You might have if the lesion is very big. So very big lesions we would not take for large volume excisions, just because that I don't think it's the amount of tissue we're removing. It's beneficial in comparing to the surgical. It's easier to do under surgical excision. So as I said, after first pass, the fibroadenoma just moved towards the needle, and we just kept needling, and this is what we had. So I think her fibroadenoma was 2.2 centimeters, and it took 18 samples with a 7-gauge to remove it completely. So you can see a little bit of air, and you will see a little bit of air and shadowing. So this needs to be kept in mind, because you may lose your visibility very, very quickly when you start hoovering, when you're looking for residual tissue. I did mention B3 guidelines. It's a very rich and a very small letters. I'm not expecting you to see them all. This is the newest updates of the B3 guidelines we would use in NHS in UK, and there's quite a lot of things the surgeons are forwarding to us now for excisions, and as I said, we're quite happy to do it. You can see sometimes there's a follow-up required, and sometimes we are taking also now the lesions with a tibia for excision. This has been thought that is safe enough. But this is outcome if the large volume excision results is not being upgraded, it's not being more malignant. So if it is, the lady would still go for a surgical excision of the coil or residual area. Just a small picture to illustrate you. So this was a breast screening patient, and we saw that she was called back for this little opacity, which turned out to be a small papilloma, 7 millimeters in size. She came for a large volume excision. We took 4 samples, and the lesion was out, and that was confirmed on post-procedural film. She said that she's allergic to titanium. So at that time, we didn't have any other markers, so we never put any marker in. But she came for a follow-up, returned for her screen and films, and there was nothing. So we did a good job at this case. Complications, nobody can avoid them. We all get them. So most of the time, we can't deal with them. So pain is something we would use locals with. So always make sure the patient is not in pain. They keep mixing sometimes feeling of very prominent pressure in the breast, which is quite uncomfortable at the time of sampling with a pain. So in that case, you ask, is it sharp? If it's not sharp, it's just a pressure. So you need to reassure the patient that this is okay, this is normal, pressure is okay. Bleeding, as I said, inevitable. Loads and loads of small vessels we can't see on ultrasound. The pressure, while the needle is in the breast, the vacuum keeps the bleeding in bay. As long as you remove the needle, the bleeding can occur. So what you're doing, you're pressing on the breast. When you're removing the needle, you press on the breast for 2 minutes and don't check it. Sometimes we like to check, well, is it still bleeding? Yes, it is. Keep it for 2 minutes. After 2 minutes, check. If it doesn't bleed, another 2 minutes. If it bleeds, just every 2 minutes. I always tend to scan ladies every time we're watching whether she's bleeding or no, because she can't not bleed outside, but the hematoma can form inside. So in that case, what you do, you just keep pressing and make sure whoever is pressing, it could be you, it could be someone who helps you, that you're pressing along entire needle tract, because if you're pressing only on skin incision, she will bleed behind at the back where the needle tip was, which doesn't make any sense. So bleeding is inevitable, but there are ways how we can cope with that. So vasovagal reaction, it most often occurs with the stereo procedures, to be honest. In the sitting position, when the ladies are lying down, it's less prominent. We have had, after procedures gone, and lady has got her lesion removed, she sits up and then she's down, just because she's so relieved in a way and all the stress comes out. So this is, again, absolutely normal. It just means she stays in your room a little bit longer. Possibility of infection is there, but it's very, very small. So you have to let your lady know what to do. So most of the time, they're just going to their GP and getting antibiotics whenever they are spotting any signs of infection in the breast. Pneumothorax, there was a case when lymph node was removed and resulted in a pneumothorax. But then again, it was prominent enough, so it was all sorted out, and it wasn't, yeah, it was challenging. It was nice. And late hematoma is something that would, nice and experience-wise. And late hematoma would be something, you're letting lady away, you're letting her go, but then she comes back because she's having this huge lump, so it has bled afterwards. Just a few of the pictures. So this is a very typical hematoma, very early one, which resulted in the breast because there was no enough pressure at the tip of the needle. And what we did, we squeezed whatever was there through the needle track out of the breast, kept the pressure, and she was absolutely fine. Even not too many bleeding. So this is another hematoma, very, very nice attempt to drain a cyst. And in the screening settings, if we're draining the cyst, we're always doing a post-procedural mammogram. And this is what we get on the post-procedural mammogram. So we not drain cyst, but filled it even more with blood. Lady came after 6 weeks. We rescanned her, and she was absolutely fine. So it did resolve, and the cyst was not visible anymore. So we did something to it, but that was the immediate result after drainage. This lady had a multicentric tumor, cancer, and they were quite far away from each other, and we tried to do the biopsy on the furthest bits. So we succeeded with 2, but one of them just started to bleed madly. So we gave up, and she came for MRI for full extent, which was planned anyway. And then MRI picked up, and they say this is a second lesion, and she came for second look ultrasound, and this is what we saw. So we just made a little pseudoaneurysm. So nothing needs to be done in these cases. We don't have to clip them or anything. It just can happen sometimes. Infection is, as I said, not very often, and you just have to make ladies aware what they have to do in case it happens. So you just see absolutely typical evidence of infection on ultrasound, and if there's no abscess, you don't have to do anything. Yeah, I'm just following my yesterday's excitement about the country I'm staying. So this is kelpies. Historically, these are in mythology, seahorses. So they come out of the sea and they drag sailors' souls in, but it's very beautiful. It looks very beautiful, so I thought I'll just show it to you as well. Thank you very much.